So I think at this point they are not ready for prime time to make decisions about what to do with patients, but I do think they're a very exciting new technology. I think there are a lot of different applications where we need a little more research before we'll be able to put them into clinical practice, but I think the biggest area where we can use these technologies, where I see the best benefit, is going to be in the disease-free survivor for whom we're considering adjuvant chemotherapy, or where we think that we can actually change the risk in terms of recurrence, utilizing ctDNA or cell-free DNA to determine who has this minimal residual disease and therefore really might benefit from systemic therapy versus the patient who maybe on paper with the stage of disease that they have should get adjuvant therapy but yet doesn't have any minimally residual disease detected. That will differentiate who will end up getting therapy. So for example, for someone who has ctDNA or cell-free DNA detected, those are patients for whom chemotherapy may be best employed, and you may be able to change the trajectory of their disease in a proportion of those patients. For those patients where you don't have any detectable cell-free DNA or circulating tumor DNA, those patients may be able to forego adjuvant systemic therapy, which has a fair amount of toxicity. So I think we need more data before this goes into prime time, but from the data that's been presented at this meeting, it's possible that this technology will be more sensitive and actually better for our patients than our current practice of CEA testing in the adjuvant setting. And so I think that's it's really exciting right now. I also think it could be very helpful in the management of patients with metastatic therapies, or the patients for whom with oligometastatic disease we're thinking about some sort of local regional intervention. If you've got someone who is going to go for a hepatic metastasectomy, for example, in colorectal cancer, but they have a detectable ctDNA, maybe that's not the patient that you send off to the operating room. And maybe there be a patient who radiographically is doing well, but you detect that cell-free DNA or ctDNA before you get radiographic progression, and what do you do with that? So I do think that there's a lot of potential for this, and I do think that is some of the wave of the future, but I don't think today that I would use it in my clinical practice outside of a clinical trial. There's a lot of very interesting clinical trials that are looking at this. The NRG has one, there are a number of institutions that have them, and there are ones that are being sort of implemented in high-risk populations, and I think we need that data before we make it a routine test. But I do think it's really exciting and interesting.